Good afternoon, everyone. I want to begin by thanking everyone who has joined us today. We recognize how busy life is, and we really appreciate you taking the time to join us for this webinar. My name is Dr. Jillian Larsen, and I'm a child and adolescent psychiatry attending at Stanford in the Department of Psychiatry and Behavioral Sciences. Today's webinar is part of our ongoing webinar series for our Parenting Center community. For those of you who are new to our webinar series and are joining us for the first time, please check out our website and YouTube channel where you can find all of our past webinars. We will be sending an email following today's webinar with this information as well. In addition, we want to share some other resources that we have available to our community. For those of you who are interested in more personalized resource, we offer online parenting consultation classes on a variety of different topics. These classes are offered in a small group format and are designed to build on the information provided during our webinars, offering additional education and scientifically based tools to support your child or adolescent. We are currently enrolling for our winter 2025 classes, and we run groups in the fall, winter, and spring. We have also just launched our first on-demand parenting class to help increase access to our resources anytime, anywhere. All the details and enrollment information are available on our website. Additionally, the Stanford Parenting Center is on social media. Please be sure to follow us on Instagram and Facebook for bite-sized science-based parenting tips and strategies. Next slide, please. So now let me just reiterate a warm welcome to everyone who has joined us today for our webinar, Parenting a Child Who is Struggling with Suicidal Thoughts, Parents' Guide to Recognizing Warning Signs and Facilitating Safety. We are incredibly fortunate today to have Doctors Oula Khoury and Morgan Matzke with us. Dr. Khoury is a child psychologist and clinical assistant professor within the Division of Child and Adolescent Psychiatry at Stanford University School of Medicine. She is the co-director of the Stanford Adolescent Inpatient Psychiatric Service, where she provides evidence-based treatment for youth struggling with suicidal behaviors and serious mental illness. Her areas of expertise are adolescent suicidal and non-suicidal self-harm behaviors, acute psychiatric care, and dialectical behavioral therapy. Her research is primarily focused on understanding unique risk and protective factors for suicide among ethnic, gender, and sexual minority youth, and on developing culturally sound clinical tools for treating suicidality in minority youth. She spent the last 10 years of her career working almost exclusively with highly suicidal youth and their families and training future psychiatrists and psychologists in this area. She currently lives in the Bay Area with her 3 teenage boys and her husband. Dr. Morgan Matzke is a child and adolescent psychiatrist and clinical assistant professor within the Division of Child and Adolescent Psychiatry at Stanford University School of Medicine. Her clinical work is divided between providing evidence-based treatment for adolescents on the inpatient psychiatry unit and for children and adolescents in the pediatric anxiety and traumatic stress outpatient clinic at Stanford. When she is not splitting her time between the inpatient unit and clinic, she can be found spending quality time with her family, walking her dogs, and searching for the best new restaurants here in the Bay Area. So we will spend the first 45 minutes today or so on this webinar with the presentation, and then afterwards we're going to have time for questions. I will be monitoring the Q&A. Any questions that you've come up, you can do it kind of as the presentation goes on. Please submit those through the chat function located at the bottom of your screen. All right, now I will turn it over to Drs. Khoury and Matzke for our presentation today.
Hi, everybody. Thank you so much for this introduction, Dr. Larsen. Well, welcome everybody again, and thank you for joining us for this parent webinar. I'm going to go over our learning objective really quickly, and we will sort of jump in. As Dr. Larsen had mentioned, we have a lot to cover, and we're pressed for time. We will start by briefly defining suicidal thoughts and behaviors and exploring common misconceptions and myths about suicidal thoughts and behaviors in youth. We will then review the most recent data pertaining to rates of suicide among adolescents in the US And we will discuss some of the most common risk and protective factors for suicide in use, as well as warning signs that you as parents can be on the lookout for that may indicate a risk of suicide or worsening mental health condition in your child. Finally, we will teach you effective strategies for asking your child about whether they have any thoughts of suicide and provide concrete evidence-based parent intervention that may facilitate safety and reduce the risk of suicide in your youth. So as I mentioned, as you can see, we have a lot to go through. So let's get started. Next slide. So let's start with defining some of the main terms that we will be using in this presentation. You will hear us talk about suicidal ideation, and I'm going here from bottom to top. When we refer or when we use the term suicidal ideation, we're usually referring to thoughts that people may have about killing themselves or ending their lives. Suicidal ideation may range in severity between what we would sort of describe as passive suicidal ideation, which refers to passive wish to die, to active thoughts about wanting to kill oneself with specific plans or time identified, which we view as more severe on the severe range of suicidal ideation. You'll also hear us mention the term suicide attempt. Suicide attempt refers to the action that individuals may take in self-directed actions that are intended to end one's life. Typically, a suicide attempt does not result in death. It's non-fatal. You'll also hear us talk about death by suicide or simply suicide, which refers to self-directed acts intended to end someone's life that actually results in someone dying. All right, next slide. All right, so how common or how concerning is the problem of suicide among youth in the US? In the slide in front of you, we share data from the Center for Disease Control about rates of suicide among youth. And we know that the rates of suicide among youth has been increasing steadily over the past 2 decades. And I would argue also increasing dramatically. Suicide is actually the second leading cause of death for children and adolescents between the age of 10 to 19 in the US. And it accounts for over 7,000 deaths a year among children under the age of 19. The graph on the left side of the slide depicts suicide rates using the number of deaths per 100,000 people among children between the ages of 10 to 14 in the United States between the years of 2001 to 2021. And as you can see, the rates of suicide have increased dramatically in this age group by more than 50% in terms of the frequency of occurrence and the rates. The graph on the right side of the slide depicts suicide rates among youth between ages of 15 to 19 for the same time period. And as you can see, also we see a similar pattern of gradual increase in rates over time, with rates increasing approximately 57% in this age group over the last 2 decades. These trends are deeply concerning for all of us who are experts in child and adolescent mental health and suicidality. In fact, the CDC has declared the problem of suicide among youth as a major public health concern due to this gradual increase as we're looking through year over year for that increase in prevalence and rates. All right, next slide. So let's take a little bit of a deeper look at closer look, I guess, at the frequency or rates of depression symptoms, suicidal thoughts and behaviors among U.S. high school students. So this data is from the Youth Risk Behavioral Surveillance System that it was established by the CDC to monitor behaviors that mostly influence the health of youth, including mental health. And it is a survey that's conducted annually with a representative sample of high schoolers in the US. As you can see, and this, I think the latest data we have available right now is 2023, which is what we have here in front of us. As you can see on the top left corner, you can see that approximately 40% of students surveyed reported that they felt so sad or hopeless for 2 or more weeks that they had stopped doing some usual activities in the past year. Um, that is 4 out of 10 students surveyed in this survey, so very common. On the bottom, you can see that approximately 20% of students surveys reported seriously considering attempting suicide in the past year. 60% stated that they have made a suicide plan. And as we mentioned, once you have a plan on board, it's considered a more serious suicidal ideation. And approximately 10% of students who were surveyed reporting having have had a suicide attempt during the past year. So as you can see from the data presented in the last 2 slides, really suicidal thoughts and behaviors are more common than one would expect in the general population of youth in the US, and has been increasing really steadily and consistently over the past 2 decades in a way that is highly concerning. Next slide, please. All right. So the next thing, in a sort of dramatic shift, I do want to spend some time exploring with you myths or facts in regards to suicide. And let's review, I really want to review some of the main misconceptions about suicide among youth and present some facts for you. As we go through the next slide, I'm going to present the statement. And because we don't have time for you guys to really engage with us or respond to those questions, just answer the questions to yourself, whether you think this statement is a fact about suicide or a myth. And then check yourself as we give the answers. So let's go through the first one. If I ask my child about suicide, I am making it more likely that they will become suicidal. What do you guys think? Fact or myth? And let's see what our expert panel said. Can you press that? All right, it is a myth. In fact, asking your child about whether they have thoughts about suicide, we have actually, research has looked into it, does not increase their likelihood of having suicidal thoughts. It actually creates opportunity for them to share and get supports, and for them to see you as someone who's willing to acknowledge any challenges that they're experiencing and be of support to them. All right, let's go to the next one. Suicide attempts or deaths are often happen without warning. Myth or facts? Answer that questions for yourself, and let's see what our expert said. A myth. In fact, there are many warning signs that indicate that someone may be struggling with suicidal thoughts, or worsening mental health that requires attention. And we will review a lot of these later on in the slides and in this presentation. Next one. Not all thoughts of suicide are the same. Myth or fact? I might have given a spoiler for this one. Let's see what our experts fact. And as I mentioned before, you guys, the thought about suicide can range between passive thoughts and very active thoughts with a plan, intent, or a specific time and location. As mental health experts and providers, we are we're concerned about all youth who are expressing or experiencing suicidal thoughts, but we are more concerned about the youth who've had active thoughts about suicide with a plan and a specific time or location where they intend to follow or act on that plan. And the last one is, if my child is threatening suicide, he or she is just looking for attention. Myth or fact? And I would say that this is one of the most common statements I hear from parents. Is this just attention seeking? Do they just need us to pay attention? So let's see what the expert said. It is a myth. And I would say we all should take any thoughts of suicide or threats or statements of suicide very seriously. We don't want to dismiss suicidal threats as attention seeking. You and us as mental health providers need to listen and get the child mental health help as soon as possible, because giving attention to statements of suicidality saves lives. All
So
right.
in the next section, we're going to go over risk factors. And risk factors are characteristics of a person or their life experiences, which increase the likelihood that a person will develop thoughts of suicide or engage in suicidal behaviors. And so there's going to be 5 large categories we divide the risk factors into. Can we go? Next one. So the first we'll talk about are psychological risk factors. These are specific to each child, and there are quite a few listed here, but let me highlight a few. Underlying mental health conditions such as depression, ADHD, anxiety, and others, in combination with a high symptom severity, so that would mean higher than average for a child without diagnosis or something that's causing significant difficulty in their life, can lead to suffering. Substance use is a risk factor as it can lead to poor decision making and making decisions that they may not choose when they're sober. Hopelessness, negative thought thinking patterns contribute to the desire to die as it becomes harder to hold on to what makes life worth living. And negative thinking patterns can intensify that reason for dying. Children who become stuck and ruminate on suicide more than other children, aka the thoughts are sticky, rather than having fleeting thoughts that come and go, are more concerning to us. Perception of having intolerable emotional pain coupled with poor problem solving elevates risk of suicide, as suicide is thought as a way to end that emotional pain for children who can feel really trapped or stuck in without possibility of change or another way out of that pain. The next category is labeled early childhood, and these are risk factors that can be ongoing for a child, not just happen in the past. This includes any history of sexual, physical, emotional abuse. Chronic medical illness includes those illnesses which require ongoing medical intervention, such as procedures, can cause pain, hospitalization, or interfere with a child's life. Or cause this unbearable pain. We know that suicide risk is heightened when pain becomes chronic and there's a high amount of distress around pain that may cause a child to feel like there's no end in sight to their pain. And this is different than short-term pain like getting a vaccine or tripping and falling. The next group of risk factors we describe as behavioral. These are specific actions a child has done which can elevate their risk. Impulsive children are at higher risk of acting on suicidal thoughts because the time between thought and action is reduced. So there's no waiting and weighing their options. Non-suicidal self-harm includes actions such as cutting, burning, head banging, but can include others. Chronic poor sleep, which we can colloquially call insomnia, rather than limited, poor sleep over a couple of nights, can lead to increased suicidal thoughts and mood lability. An important risk factor here to highlight is that one of the best predictors of future suicidal behavior is past behavior. So the number of suicide attempts that a child has, kind of the higher the number, the higher the risk that this will happen again. And so next we're going to move on to the social factors, which are influences in a child environment that are outside of the child, which can significantly influence their risk. Bullying, whether it be in person, virtual, verbal, or physical threats to safety, can or derogatory in nature really impact a child's sense of well-being. Important to note here is that there is a contagious effect to suicide. Knowing someone who has died by suicide can increase a child's risk of having suicidal thoughts or behaviors themselves. Media definitely has a role, particularly when describing a person's pain after they've died by suicide as being gone, that they're in a better place, or highlighting the method or means in which that person died by suicide. Family and peer conflict in combination with social isolation increases a child's sense that they don't belong. Declining grades, failure, struggling in classes can contribute to hopelessness and thoughts of dying. Having access to means, so ways in which a child could end their life, is one of the risk factors which we're going to talk about later, but it significantly increases a risk of acting on suicidal thoughts. Research shows that having a family history of suicidal behaviors or death by suicide increases that child's risk, even if they aren't aware of how that person died or that a family member has had suicidal thoughts. Children who are unconnected to are more likely, unconnected to mental health resources are more likely to have unrecognized suicidal thoughts, and drivers of suicidality can go untreated. Lastly, it's important that we acknowledge the impact of youth who are marginalized. Emma, can we go one more? Awesome. So the impact of youth who are marginalized, who have a marginalized identity, including identifying as a minority, race, ethnicity, sexual or gender identity, as these experiences of discrimination and microaggressions that they can have contribute to a feeling of not belonging and increase their desire to die, as their identity is immutable. Next slide. While there are risk factors to be mindful of, there are also multiple protective factors against suicide. And these are individual characteristics, skills, resources, which help youth reduce the negative outcomes and impact mitigate the risk factors that we just talked about. Psychological factors, again, there are going to be 4 now. Psychological factors are, again, the traits inherent to a child. Having high self-esteem and self-compassion leads to children being more flexible for their perceived errors, rather than being driven towards towards dying because they made a mistake. As we spoke about, strong problem-solving skills allow a child to get out of situations which are stressful or contribute to the desire to die, and may not produce hopelessness because they can see a way out, rather than kids who have poor problem-solving skills. If a child does not have hope about the future, if a child has hope about the future and what's to come, then they're more able to cope with the now, even if they're really struggling, rather than considering death by suicide as that way to end their pain. There are also cultural and religious factors that can impact whether a child has suicide on the table. Social protective factors are a component, again, of a child's world that are external to themselves. Having a strong sense of social connectedness and being tied to the world through relationships, including peer and community support, being involved in a religious organization, club, or group, help to foster that connectiveness. And studies show, in fact, that even a single teacher at school who a child identifies as supportive can be protective against suicidality. Children who have strong sense of belonging have a reduced risk of acting on suicidal thoughts due to feeling tied to life through their relationships. Family factors are ones which, as parents, are kind of more within your realm of control and somewhat outside of a child's realm of control. Taking action on these protective factors are going to be reviewed specifically a little bit later, so I'm going to be brief, but essentially evidence supports restricting access to means of suicide, increasing supervision, and becoming more involved in a child's life as protective against suicide. Close relationships with parents and higher cohesion within families can also reduce suicide risk. Lastly, access to mental health resources, particularly evidence-based therapies, and having a strong connection to a therapist or psychiatrist reduces suicide risk. Next slide. Now let's go over what you should look out for if you're worried or you know a child is struggling with suicide thoughts. We categorize these warning signs in 2 buckets for the sake of helping you decide how urgently to take action, primarily as warning signs where a child's mood is worsening and they require mental health evaluation urgently but not emergently, and others where there are signs concerning for imminent, aka near future, risk and require immediate action by you as an adult. Emma, will you click one more? Thank you. So first, we're going to look at the left at the warning signs of urgent but not emergent evaluation. These include you noticing our child stating they're sad, down, they're more frustrated, irritable, particularly than their baseline. They have changes in sleep and appetite. They're not as motivated towards hobbies they may have liked, withdrawing from family, friends, their academics are declining, they're complaining they can't concentrate. Maybe they have worsening reckless behavior such as substance use, leaving the house without caregivers' knowledge, or other behaviors that can put their life at risk, but not imminently as in the near future. Mental health can have an effect on the body, so new physical complaints definitely see a pediatrician, but don't necessarily need emergent intervention. And then lastly, increasing use of substances, alcohol, or other recreational drugs can be a sign that they're struggling with negative emotions. And so while those signs are definitely concerning and warrant care from a licensed mental health provider, there are actually signs that are more worrisome to us, or which you should notice that need to be acted on immediately. And that's going to be this right column on your screen. These signs include talking to others verbally, through text or on social media sites, about wanting to die, having a plan to die, feeling hopeless, that they are a burden on others. If a child is seeking means to kill themselves by gathering methods such as medication, sharp, obtaining a firearm, or you discover that they've been searching on Google lethal doses of medications or ways to die by suicide, this is very serious and signals that a child may be actively contemplating dying. If a child expresses unbearable emotional pain, such as, I can't keep living like this, take this seriously. Remember back to this being a risk factor for suicide that I just talked about. If you notice a child saying goodbye to people or visiting them, making statements that signal finality, or you find goodbye letters or texts, this is another very concerning sign. Children start giving away their prized possession or objects that hold meaning to them. This can be a sign that they are contemplating death by suicide because they're no longer in need of these possessions and they want their loved ones to have memorabilia of them. Lastly, if a depressed child all of a sudden becomes calm, cheerful, appears like a weight's been lifted off of them, this is actually can be a sign of relief that the child has decided to die or has decided to have a suicide attempt, and needs emergent evaluation. So my goal for you as caregivers is to take away that if you're seeing these signs or are worried about your child, please take them in for an evaluation. Next slide.
All right. So, let's say you've noticed that your child is experiencing some of the risk factors for suicide that Dr. Matzke had just reviewed with you, or that they're showing some warning signs and you're concerned about them. And the next step is going to be finding a way to ask your child about this very difficult and challenging topic, asking your child directly about whether they're having any thoughts about suicide. And for this section, I want to give some credit to the Be Sensitive, Be Brave suicide prevention program and Dr. Joyce Chu, who's created it. And it's a community-facing suicide prevention program that teaches individuals who are not mental health providers, including youth, teachers, and parents, on how to identify the warning signs and how to ask and connect people to care for help. So, general guidelines for starting the conversation with your child would include one of the most important aspects, I would say, is being mindful of your own emotions when you're talking to your child about this topic. Staying calm and well-regulated is key. While, your child will often sense if you are experiencing some distress, anger, or feeling just anxious about approaching the topic. Typically, children who, sense this unease with the individual, with the adult who's trying to have this conversation, will shut down, may minimize some of their experiences, or be reluctant to share. So really very important to pick a time where you're feeling well-regulated and up for the task. A big part of being well-regulated is being aware also of your body language. And maintaining a calm and open body language is going to be key, because that also communicates to your child that you're comfortable talking to them about this topic, and you genuinely want to be there and can handle hearing whatever they want to share with you. And I will say just one last thing about this last slide is, as a parent of 3 teenagers myself, I can definitely understand that as parents, our immediate urge when our child is experiencing some distress is to jump in, problem solve the issue, giving advice or fixing it, the wanting to fix it. However, what we know is jumping in too quickly with problem solving or trying to fix away the issues may also cause kids to shut down, withdraw, and not share anything with the person who's talking to them. So I want you to hold on actually and resist that urge. There'll be plenty of time later on to problem solve and try to help your child with the issue. The first step is really coming into that conversation openly asking the question without judgment and really being curious and wanting to learn more about what your child is experiencing. All right, next slide now. So there are two parts to the skill of asking about suicide. The first part that we were going to talk about is what we're going to call be sensitive. It emphasizes this human connection, child-parent connection, and having your child feel at ease with the conversation. The second part we're going to call be brave, which talks about ways or strategies to ask direct and clear questions about suicide. So let's jump right into it. Next slide, please. Okay. So we want to start the conversation, and you want to sort of present to your child some of your concerns or context to why you're asking them about it. And as we mentioned before, you may have noticed some warning signs or noticed that they're experiencing some risk factors prior to initiating this conversation. So the first step is going to be stating your observations without judgment in a calm and empathetic manner. Some examples on this slide for you guys is something like, saying, I noticed that you don't seem to be yourself lately. Or lately, I've noticed you've been spending a lot of time in your room and seem sad. I'm worried about you and I want to check in. Or you can say, something to acknowledge the difficulty of even having this conversation. I know it can be difficult to talk to your parent about how you're feeling, but I'm concerned about you. How are you doing? The last one example here is if you've noticed a certain stressor that your child has been experiencing. This could be in teenagers, a breakup or stress in school and academics. So you can start the conversation by saying, I know you have been dealing with a lot of stress lately because insert the specific stressor of your child. And I can imagine that hasn't been easy. Tell me how you're doing. Right? We're starting the conversation. We're asking open-ended questions that are general. We're establishing ourselves as, hey, I'm worried about you. I'm noticing things. I want to be there. I want to hear what's going on. Next slide, please. As you're entering this conversation, we talked about the importance of maintaining your sort of being aware of your body language, but also we want you to use active listening skills that include maintaining eye contact and really letting go of any distractions in the surrounding. Put away your phone, put away any other distractions. Make sure that you have time and sufficient time to talk to your child about this without distractions from other family members. Let go of judgment and try to avoid using terms such as this is good or bad, or this is helpful or not helpful. Listen without planning your response. Oftentimes, I have seen, especially when we're nervous about a conversation, we may be planning what we want to say to support that person while that person is sharing the information with us. What that does is it distracts you from listening closely and understanding what your child is going through. So we recommend that you really not plan your response. Focus on listening to your child. And definitely do not interrupt them. Give them an opportunity, if they're talking, to just tell the full story and save your questions, which you should have more questions, to the end. And the last point here is assume you don't understand what your child is experiencing and ask more questions openly with curiosity. Some of the most common thing that we hear parents say is, I know exactly how this feels, or I may have experienced something similar to what you're going through when I was your age. And when we do that, we shift the attention from what your child is going through to what you have gone through in the past. And we also make assumptions that your child's experience is similar to yours. And instead of making those assumptions, we just want to be curious about them and hearing their perspective. Next slide, please. All right. So you want to continue to build rapport and show your child that you care about them and that you notice or acknowledge what they're going through. So we talked about that you're sort of sharing your observation, right? I noticed you've been having a hard time. And I want to check in with you. How are you doing? Once your child does share with you, how they're doing or how they're feeling in general. I want you to try to repeat what you heard or restate what you heard your child tell you. This is a strategy that we often use also as mental health providers, and it helps the child feel that they've been heard, and it also helps to check that you understood or heard them correctly. So it sounds like, and repeat what your child says. Respond with empathy and, make statements that, such as, that sounds really difficult. Even if you can't see their challenges, I would say do not question the reality of your child's pain just because you can't see it or relate to it. Focus on validating their emotions and saying statements like, this must be really painful for you, or I can see how this is really painful for you. And lastly, acknowledge the difficulty to share and praise them for actually being brave in sharing how they're feeling or what's going on with them. All right, next slide, please. We talked about validating your child's emotion, and I want to talk about two things that are really important here in this process as we're having this conversation. One is validating their emotions, and the second is normalizing their experiences. Validating their emotions speaks to communicating to your child that it makes sense that they are feeling in this way, given what they are experiencing or going through, or that other people in their shoes who maybe have gone through something like this feel similarly. Validating your child's emotions, even if you disagree with some of their choices or behaviors, is critically important for them to hear understood and feel comfortable continuing to share with you. The second part I talked about, normalizing. Normalizing is really framing their distress in the context of this is a normal response considering the circumstances or the experiencing you're having. In the second example on this slide, you will see, for example, an example of that. You are dealing with a lot right now. I know that for many of us, when we are dealing with this kind of stress, sometimes we have difficult thoughts. And that is, in fact, accurate. For a lot of people, when they're dealing with a lot of stress, they do have difficult thoughts. And we already saw the prevalence rates of suicidal thoughts among adolescents. That's a very common thing. And make sure to remind them, remind your child that you care about them and that you want to make sure that this person is safe, your child is safe, and that you support them properly. All right, so you've set the stage, and we're going to the next part, which is the be brave. Be brave is about asking a clear and direct question about suicide to your child. And this is where a lot of people have a really hard time asking sort of bluntly, but you've set the stage, you've expressed your support to your child, you've listened to how they're feeling, you've shared your concerns and observations with them. And now it's time to ask that question. And the best way to ask that question is to ask it directly, because there's no way we can know if someone is thinking about suicide unless we're asking them directly. Some example questions you may use is, are you having thoughts about suicide? Or are you having thoughts about killing yourself? Are you having thoughts about ending your life? I'm giving you here variations on the same questions. If asking that directly feels uncomfortable, you may start with maybe a gentler question like, have you wondered if life is worth living, given all of the hard things that you've experienced? Or have you ever thought that others will be better off without you? Could be a gentler way to ask, a softer way to start that conversation. But also, I need you to end up with a direct question. Are you having thoughts about suicide? Are you having thoughts about hurting yourself right now as well? All right, next slide, please. So in the next slide, I just have really brief do's and don'ts, or say or don't say. We really don't want you to communicate to your child and say, I know what you're going through, because none of us truly know fully what the other person is going through. Instead, say, tell me more about what you're going through or what you're thinking. The two questions after this talk about just how to phrase our question so it's more neutral and less leading. One says, you're thinking about suicide, aren't you? Or you're not thinking about suicide, are you? We actually don't want you to use that type of tone or statement. And we prefer if you just ask, are you thinking about suicide? Because the latter version is more neutral and does not sort of indicate that you are hoping that the child will answer the question in a certain way. And definitely, we don't want you to say some of the last two statements or common statements that sometimes parents do say that are unhelpful to children, which is, this is what you get for not taking your medication or going to therapy or not even trying to work on this, right? Any blame or finger pointings, even if you're correct, maybe your child has not been going steadily to therapy or working on trying to get better. In this moment, pointing fingers or blaming is going to distract from the goal, which is your child to tell you how they're feeling and also to make sure that your child is safe. We can get to those problem solving and solution focused issues later once we've established safety. So instead ask, how can we keep you safe right now in this moment? Another common statement from parents we hear is, what do you have to be suicidal about? Your life is greater or compared to other kids your age or compared to what my life looked like when I was your age. Well, that may be true. Making this statement can be experienced as very much invalidating to your child, communicating that their emotions don't make any sense and they should not feel the way they feel given what they have, and that will automatically cause them to more likely to shut down or minimize what they're sharing with you. Instead, we propose that you say, I'm glad you shared these feelings with me. Let's talk about how we can get you some help and keep you safe. All right, giving it back to Dr. Matzke.
Now we'll transition to what you can do as caregivers when you've identified that your child is struggling with suicidal thoughts. And we're going to walk through 4 steps which you can take before ending on a slide with some national resources. So make sure to have your phones ready so you can take a snapshot, or you can snapshot it on your computer. Next slide. So first step is connect your child to mental health providers who can do a full assessment of what might be going on with your child. It's not up to you to figure it out as parents. If you're seeking an individual therapy provider, we recommend dialectical behavioral therapy or cognitive behavioral therapy for suicide prevention, as these are 2 manualized, evidence-based types of therapy which have been consistently shown to reduce the risk of suicide in adolescents. Even if you're on the fence or not sure whether a child with suicidality requires medication, it's really important to get connected to a child and adolescent psychiatrist. Psychiatrists are trained in both medication and non-medication treatments across the spectrum of mental health diagnoses and can work collaboratively with you and your child to move forward, including with or without medications. And as an additional point, because I'm a child psychiatrist myself, medications can be key to reducing the suffering of a child and help make progress, in addition to other non-medication interventions such as therapy, school accommodations, and such. Next slide. So next, let's talk about what parents can do to reduce conflict. Remember back to protective factor slide where I said that close relationships with parents and higher familial cohesion was protective against suicide in youth. Research has found that having high levels of negative expressed emotion in a home increases suicide risk. So what is negative expressed emotions? It is what you might think of as conflict or negative feelings that comes out in a home between caregivers and children. This can look like yelling, cursing, arguing, name-calling, blaming a child during an argument, bringing up past episodes where they've done something wrong that's upsetting to you, as broke the rules, or lobbing criticism. While it's inevitable that there will be times where you and your child are frustrated, upset, annoyed, the way you handle this as caregivers will make all of the difference. Staying calm, open, even in the face of conflict, and leaving any blame and criticism of the child as internal thoughts rather than external statements can be life-saving. So when your child is saying that they are feeling unsafe, this is not the time to bring up baggage or sticking points in your relationship. So what can you do? Validate your child's emotions and offer support, just like Dr. Khoury reviewed earlier with the Be Sensitive, Be Brave model. Most importantly, keep your voice calm and your demeanor calm. Even if you are yourself feeling negatively, it's important to take a deep breath, manage your emotions. If you're feeling really hot, it's going to be really hard to show up emotionally for your child. Also, pick your battles. Not everything that you want from your child when they're struggling needs to happen. And this is a personal family decision, but decide, is this chore or expectation worth pressing on right now? Or can I temporarily let this go in favor of providing support? Now, let's talk about what to avoid. As I said, anger, disappointment, shame, not helpful, and in fact, harmful to a child who's struggling with suicidal thoughts. Making invalidating statements and expressing doubt, such as, last time you said this, you just didn't want to do your homework. Well, it's not helpful in that moment. And we strongly recommend taking expressions of feeling unsafe and suicidal thoughts seriously. Next slide. The next important step for caregivers to take is to remove access to ways in which a child could end their life. Studies have shown that a portion of suicide attempts occur in the heat of the moment, when emotions are high, during crisis. Not having access to ways in which a child can make a suicide attempt is life-saving. The harder and longer it takes for someone with suicidal thoughts to access a way in which to end their life, the more time they have for emotions to settle and for them to contemplate whether acting on those intense emotions is what they want to do, or maybe they can choose an alternative path or a different way of coping. And so our next slide is one that I want you to take a photo of if you're able to, so that when you're going through your home, you can be as thorough as possible in reducing a child's means to harm themselves. So first, lock up medications, over-the-counter prescriptions, vitamins by placing them in a lockbox or a cabinet. Throw out expired, unused medication. I'm sure we all have it. It's just amazing what we collect over the years. On the same note, make sure to keep track of medication. This way you'll know if some goes missing. Next, if your family has firearms or ammunition in the home, our strongest recommendation from a suicide safety perspective is to not keep them in the home. If this is impossible, then we recommend placing the gun in a gun safe and having the ammunition locked separately and away from the gun. We do not recommend keeping a loaded gun at home or a gun unlocked with ammunition nearby, because firearms are one of the most lethal ways in which people die by suicide. We also recommend collecting and securing sharps, including but not limited to knives, scissors, razors, sharp tools. Go through your home, including the garage and any outbuildings where things may be hiding, to pick up these items. This is particularly true if your child is struggling with self-harm, as limiting access to sharps can be used for cutting. Even if the child denies having suicidal thoughts, they say, no, I'm not doing this to try to end my life, is really critical, because again, self-injury is a risk factor for eventual suicide. Ligature wrists are something that someone can use to hang themselves or you put around their neck to cut off oxygen to their brain. This includes belts, ropes, extension cords that are not being used. After removing what you can, there may be cords that just need to stay around the house. So in this situation, we recommend using zip ties, so gathering the extra length of an extension cord and zip tying it to make it as short as possible. Lastly, we recommend locking away chemicals, alcohol, other cleaning products, which can be toxic if ingested by a child. In many houses, caregivers can place these items, which understandably, you might use on a regular basis for cleaning, in a cabinet with a lock, or another lockbox if you have one of those as well. It can also make sense to eliminate unneeded toxic cleaning products, removing alcohol, marijuana, or any substances from your home, even if you as parents are recreationally using it. As we mentioned, that substance use can disinhibit a child and make them at higher risk for having suicidal thoughts or acting on those suicidal thoughts. And I want to stop by recognizing that this is a lot of work for you as caregivers, and it may take some time to complete. Next, we've mentioned the importance of understanding and identifying drivers of suicide for your child, but it's really common for parents to say, but I just can't remove everything from their life. And you're right, not all stress is avoidable, nor should it be. That is turning down the stress is like a dial. You can reduce the intensity to the point where children can regain feelings of being in control and reduce a sense of hopelessness surrounding stressors while the child is getting help for their mental health symptoms. So what does that mean for you? think about your child's life, identify what is causing the stress. Common drivers include academics, expectation, challenging schedules, poor sleep, feeling alone, isolation, and family conflict. However, you know your child best, and it's going to be unique to them. Next, work in collaboration with your child, their school, the treatment team, and any other key players in your child's life to pick what has to happen now and what's a nice to happen now. A common example we talked about parents is in the short term, academic expectations can be lowered in order to get your child more help. This may mean dropping an AP class or the extra class they're taking in order to have time for treatment. As JFK said, but with a little twist, ask not what your child can do for you, but what you can do for your child when it comes to reducing drivers of stress. And this last slide I want you all to take out your phones and take a picture of is resources to keep on hand, including the National Suicide Crisis Line, the Crisis Text Line, the Trevor Project. All three of these have free 24/7 call text lines for children or you to use if anyone's in a suicide crisis. And lastly, the American Foundation for Suicide Prevention has a national nonprofit that has resources, support groups, and information about suicide prevention. That can be a good place for you all to seek. And I want to end by saying thank you for coming to your talk. And does anyone have any questions?
All right, thank you both so much. This was incredibly informative and I think hopefully very helpful. We have some great questions from some of our attendees today. Also, just a reminder, if anyone else has questions, please feel free to put them in the chat at the bottom. We'll try to get to as many of these as we can. So the first one is, if I'm worried about my child, that my child is at risk for suicide and they don't want to talk about it, is it okay to monitor their internet use or look at their phone or search history?
And I'm more than happy to take this one. So there's varying degrees or like debates about this, but I can tell you what we recommend as clinicians and people who work with, children who are suicidal, and the answer is simply yes, it is okay. We actually, in fact, recommend using any child monitoring software and install that on all electronics at home. Oftentimes, we definitely, especially in the world we live in around electronics, we see that children may use search engines to search for ways or plans of how they can end their lives, or may communicate to peers or friends online or via text or on social media platforms their intention or feelings around suicidality. And some of the monitoring apps, such as the Bark app, can help you catch some of those online activities and alert you while maintaining your child's privacy, alert you to those risks early on so you're able to intervene.
Okay, thank you so much, Dr. Khoury. For our next question, I think it's referring to one of the early slides in this presentation, which is one of the graphs kind of looking at rates of suicide. And the question is, why do you think there was a spike in suicide between 2017 and 2018 in both of those sets of youth groups? So I think it was 10 to 14 and 15 to 19.
Yeah.
Oh, thank you,
Thanks
Emma.
for pulling it. I really love this question. Thank you for whomever asked this question, and also like very, very good observation.
Perceptive,
So,
yeah.
yeah, very perceptive on those graphs. And so I'm going to start by saying we never know definitively why a spike occurs or an increase occurs, especially a dramatic increase such as what we're seeing in those slides. I will say, though, that there has been one published paper by Jeff Bridges and the Center for Suicide Prevention and Research at Nationwide Children's Hospital that looked at rates of suicide or demonstrated a significant spike in rates of suicide after the release of the TV show 13 Reasons Why, which was released, I believe, in April of 2017, which is around the time where we're seeing this spike. And their research showed that there was a 28 or 30, almost 30% increase in suicide rates among youth in the US in the immediate aftermath or period following the release of that series. I see the comment of the person who asked that saying like that was what I thought. Yes. And now we talk oftentimes, there are guidelines for around suicide preventions for safe media depiction of suicide, safe ways to even share information about celebrities who die by suicide, because the risk of contagion is so high in the population of youth, that we want to be extremely cautious of how we talk about suicide in a way that does not glorify it or depict very vivid and graphic images of self-harm and suicide.
Okay, thank you very much, Dr. Khoury. Okay, for our next question, it's should I tell my child's school that my child is struggling with suicidal thoughts? And kind of a related question, should I take my child out of school?
So I can take this. So first, about whether to take your child out of school, we typically recommend to continue to have a child in school. As I mentioned in the risk factors, that academic decline or perception of getting behind and failing can actually be a risk factor. So by removing the child completely from school, you can unintentionally increase that risk, right? Or have a child feel like they are falling more behind. Now, the question about whether to have a child, to tell your child school directly, I think is definitely a personal decision within a family. However, if there is such significant risk that a child is unable to be safe at school and they need additional supports and accommodations, then it can be important to talk to a school about it. I think this is really where having a care team is so important, because being thoughtful in the accommodations that are placed in school. Sometimes kids have a quiet space. There may be a wellness center or something that they can go to. There may be a in-school therapist who they can go see. And in that case, that may be a protected person who can know about the child's suicidality. And that doesn't mean that everyone at school needs to know, or that they have a right to your child's kind of protected health information.
Thank you, Dr. Matzke. So we're almost out of time. I'm gonna, if it's okay with our presenters, just read one more that I think seems really important from one of our participants. So it says, do I need to take my child immediately to the emergency department if they're telling me they have thoughts about suicide? And kind of as how do they know when they need to go to the ER?
Dr. Larsen, it's almost like you're most qualified to answer that question, but
That's fair, but I will turn it to you guys.
feel free to jump in if you have anything to add. For those of you who don't know, Dr. Larsen serves primarily at Stanford in the emergency department, and oftentimes is the person assessing kids who will end up in the emergency department. I mean, let Dr. Morgan or Dr. Matzke or Dr. Larsen answer this.
Sure. So I would say that it depends on what your child is talking about and whether you have created a plan around what happens if your child says that they have suicidal thoughts, with the caveat that if you are feeling unsafe, if that child says, hey, I can't keep myself safe right now, then it is not a wrong decision to take your child to an emergency department to get an evaluation. Full stop. If you are unsafe as parents, you should not be managing this alone. Getting extra care can be really helpful. However, not every expression of having suicidal thought needs emergency care, nor does it need inpatient psychiatry. And that's why we make plans around, okay, how do we increase monitoring, right? If the child say, hey, I'm having these thoughts, like Dr. Khoury had said, asking them about them, and then collaboratively, okay, well, how do we keep thank you so much for telling me and sharing that with me. How do we keep you safe? And that may mean that, hopefully the means restriction has happened in your house, but if it isn't, definitely take those things away, and then increasing the monitoring. Maybe you're sitting together, maybe you have eyes on that person and you're reaching out to their care team to get more support and increase the level of therapy interventions or medication that may help them.
Yeah, so I agree completely, Dr. Matzke. I think, again, as it's a conversation, so if your child is sharing these thoughts, I think a really appropriate question is, do you feel like you're safe at home? And if your child says no, I think that's a clear indication to bring them to the emergency room. I think if you feel uncomfortable or really on the fence, like Dr. Matzke said, is it's never the wrong choice. And we're always happy to see and evaluate kids in the ER and so that you have another set of eyes on them and kind of an expert opinion about the level of risk and to be able to discuss kind of what are other options to keep them safe. All right, well, thank you both so much. We really appreciate your time and expertise. And thank you so much for those of you attending. And we hope you learned something today. And please, I think Emma we will send out kind of the email with additional parenting center resources, and we hope to see you at future webinars.
Thank you.